We will proceed with the next talk, which will be my own, and I'm going to be talking about the surgical management of intrahepatic cholangiocarcinoma. And as been noted, as surgeons, most of the time, at least in my practice, this is what happens. Somebody may, have some vague symptoms, and a CAT scan is obtained or an MRI is obtained, and then there's a mass in the liver. And then the question becomes, what is the mass? Is it a primary tumor of the liver? Is it a secondary tumor metastatic from another site? Typically what happens is when someone sees a mass in the liver, they stick a needle into it. And then the question becomes, when the diagnosis is adenocarcinoma, again, is it a primary or secondary? And we heard from our previous speaker about the different immunohistochemical tests that can be done on the specimen to help elucidate whether this is truly an intrahepatic cholangiocarcinoma. Some of the things that will be looked for are biliary dysplasia. And then we heard about the battery of immunohistochemical stains that will be done on the specimen to rule out other potential primary tumors such as lung or colon or even pancreas. And then a battery of IHC stains that will help rule in a primary that is consistent with biliary epithelium. And typically, our hepatopathologists are now pretty good today, and they'll tell you that this is very likely to be an intrahepatic cholangiocarcinoma or something from a biliary origin. Despite that, I think it is important to make sure that we rule out other etiologies of a mass in the liver with a histological diagnosis of adenocarcinoma. We do routinely send off serum biomarkers, but it's important to note that while these are specific, they're not incredibly sensitive. There will be a subset of patients that can have hepatocellular carcinoma or intrahepatic cholangiocarcinoma and have completely normal AFP, CA19-9, or CEA. It's unlikely, however, if these markers are extremely elevated, that it would be a false positive. So it is helpful to obtain these serum tumor markers. I also think it's important then, as a surgeon, when you see these patients, to rule out other primary tumors. So if I have a female patient, I'll make sure that they're up to date on their mammogram or gynecologic exams. And then I'll selectively use upper and lower endoscopy. I've definitely had patients referred to me for intrahepatic cholangiocarcinoma who ended up having a colon cancer. I remember another patient who ended up having a gastric cancer that was metastatic to the liver. So it is important that one does fully rule out other primary tumors that could be masquerading as a primary intrahepatic cholangiocarcinoma, but indeed is representative of metastatic disease. As we heard from Dr. Kamel, really the workhorse of working up this disease as surgeons is cross-sectional imaging, CT and MRI. And then also, as touched upon, I tend to use PET fairly frequently in a population of patients who I'm suspecting intrahepatic cholangiocarcinoma, and perhaps ironically, perhaps even more than I would for patients with colorectal liver metastasis. And I'll explain my reason for that as a surgeon later on. We heard from Dr. Kamel that there are different morphologic subtypes of intrahepatic cholangiocarcinoma. And as surgeons, it's important for us to be familiar with the different morphologic subtypes, whether it be intrahepatic, mass-forming, periductal, or interductal growth pattern. And you can see here the different morphologic features of these tumors, with mass forming, having this classic capsular retraction and a hypodense lesion, the periductal infiltrating, having these dilated duct with the enhancing rim of the duct, and then the intraductal growth pattern having this kind of ductatasia. When we talk about intrahepatic cholangiocarcinoma, however, we're mostly talking about mass-forming lesions. If we look from data from the Liver Cancer Study Group of Japan, or even data from the United States or other areas, about 80% of these intrahepatic cholangiocarcinomas will be mass-forming. And it's important as surgeons to have a certain, ease or familiarity with different modalities of imaging. It's been my experience that many surgeons are much more comfortable with CT than they are with MRI. But at least in my practice, I typically favor MRI over CT. And again, as Dr. Kamel alluded to, MRI is fairly sensitive and specific for differentiating intrahepatic cholangiocarcinoma from hepatocellular carcinoma, whereas hepatocellular carcinoma tends to be a soft tumor in a hard liver if it's cirrhotic. These intrahepatic cholangiocarcinomas tend to be very fibrotic tumors, so they only tend to enhance usually in the later phases of the scan. And then you can see here in panel B, they have this peritumoral ductal dilatation. So even though I rely heavily on my colleagues such as Dr. Kamel, I think as surgeons, we need to obviously look at our own scans and have some familiarity. And in looking at a scan like this, we as surgeons should have a high suspicion for intrahepatic cholangiocarcinoma. And then again, on this MRI, you can kind of see some of the pathognomonic features with the capsular retraction, this late enhancement, central necrosis, and then peritumoral ductal dilatation. As was noted again by Dr. Kamel, these lesions tend to be FDG avid. And so I tend to use PET for a number of reasons. One is that sometimes you can identify an occult primary tumor that you didn't suspect on a PET scan. And then you can also sometimes identify occult metastatic disease. And Dr. Kamel showed that image where a patient had intrahepatic metastasis in the left hemiliver that were much better identified on the PET scan than they were on the cross-sectional imaging. And then you also may find evidence of FDG avid disease in the nodal basins, either in station 12 in the perihilar area or even beyond station 12. And at least in my practice, if I identify nodal disease in the preoperative setting, I'm much more inclined to treat that patient with preoperative neoadjuvant therapy rather than take them directly to the operating room, because as I'll show, the data would suggest that patients with preoperative nodal metastasis have a very high incidence of recurrence and even a very high incidence of very early recurrence within the first 6 to 12 months after surgical resection. So about 15 or maybe even 20 years ago, we put together the Intrahepatic International Consortium, which is now made up, I believe, of more flags than this. I need to update the flags, but about 18 to 20 centers from every continent in the world, except from Antarctica. We've been able to collaborate and collect data on well over 1,000 patients with resected intrahepatic cholangiocarcinoma. And for surgeons who take care of patients with this disease, we know this can be a technically challenging disease to treat surgically. Many of these patients, as we heard from Dr. Washington, present with vague symptoms or asymptomatic. And so by the time their disease is diagnosed, the tumor can be quite large and also be located in challenging situations. This is a patient of mine who has a relatively large lesion located in the central portion of the liver that's involving segment 4B, but also segment 5. You can see that it is involving the anterior sectoral branch of the right portal vein and abutting the posterior sectoral branch of the portal vein. So this is a large tumor in an inconvenient location and really would necessitate an extended right hemihepatectomy, which is exactly what we did. And you can see this picture after the specimen has been removed at the base of the umbilical fissure, segments 2 and 3 of the bile ducts, because we had to perform an extrahepatic biliary resection also in order to completely extirpate this tumor. And then you can see the portal vein and the hepatic artery. But even despite these very large operations, the margins that we're able to achieve at the time of surgical resection can be somewhat close, and it can be difficult to achieve a wide negative surgical margin. So here's another patient of mine. This is a patient who presented with the lesion in the left hemiliver. Here are some representative cross-sectional images. What you may or may not be able to appreciate is that we can see the vena cava up here to the far left in the right hepatic vein, but the middle trunk of the left hepatic vein and the middle vein could not be visualized, and there was some concern that there was involvement of the common trunk up to the vena cava. and it was unclear whether I could gain purchase, if you will, on that common trunk. And because of the extent of this disease and some satellitosis around the disease and a CA19-9 that was in the range of about 500, I elected to treat this patient initially with some systemic therapy, and then following systemic therapy, actually treated this patient with Y90 to the left hemiliver. After that, I took the patient to the operating room and performed a left hepatectomy, or a little bit of an extended left hepatectomy, and was able to remove the entire tumor. We were able to get above the left common trunk and divide the common trunk right on the vena cava. And actually, this patient is alive about 2 years later, free of disease, doing well. Interestingly, on the explant, there was about 60% viability of the tumor, despite having been treated with preoperative chemotherapy in the Y90, which I thought was interesting, and perhaps we can discuss later. This is a different patient that I treated. This is a patient who presented with a very large tumor in the right hemiliver, who actually was jaundiced, presented with an elevated bilirubin. You can see that the right hemiliver is severely atrophic, with some compensatory hypertrophy of the left hemiliver. You can also see a biliary stent that we placed. And then perhaps most concerning is that you can actually see some ascites outside of the liver. This patient, you can see on the coronal images, was similarly treated with preoperative chemotherapy. He had an extremely high CA19-9 of over 100,000, but had a good response to chemotherapy. His CA19-9 came down markedly. It didn't normalize. I think it was below 1,000, and most of his ascites resolved. I don't know if Dr. Rorachari treated this patient or not. I can't remember, but maybe Samit can comment later. And rightly or wrongly, I ended up taking this patient to the operating room and performed a right hemihepatectomy on this patient. But unfortunately, this patient recurred within a year, and then has subsequently succumbed to his recurrent disease and died. So I think these cases kind of highlight some of the technical challenges of big operations, extended right, extended left, but also some of the difficult clinical decisions that we face as surgeons about who to operate on, who not to operate on, treating these patients with preoperative chemotherapy, preoperative regional therapy like Y90, and then making decisions about whether we should take them to the operating room after preoperative therapy. At the time of the surgery, one thing that is a big concern is margin status, right? As liver surgeons, we love to talk about anatomic versus non-anatomic resection. I think most of us agree that there's fairly robust data from China and Japan and other places that for hepatocellular carcinoma, that the tumor tracks along the portal triads, and that there may be a survival benefit associated with a truly anatomic resection. At least data from our group in examining over 1,000 patients who have undergone resection, there did not seem to be a survival benefit versus anatomic versus non-anatomic resection. So I do not believe that we must do anatomic resections for patients with intrahepatic cholangiocarcinoma. However, as these data demonstrate in a separate paper, there clearly is a benefit with regards to overall and recurrence-free survival in obtaining a negative margin, and one should try to achieve at least a 5 millimeter and at least ideally a 10 millimeter negative margin at the time of surgery. Sometimes in order to obtain this negative margin, we need to do a vascular resection. And these data demonstrate that if we need to do a vascular resection, one should proceed with doing that, because long-term patients can have the same overall outcomes as patients who did not have a vascular resection. However, one must note that there is increased perioperative morbidity and mortality, which can be as high as 8 to 10% following complex vascular resections and reconstructions. And therefore, these procedures should only be done at expert centers that are high of volume. One thing that is important is to recognize how we stage intrahepatic cholangiocarcinoma. And it's interesting to note that the first 6 editions of the AJCC UICC staging manual had no staging system for intrahepatic cholangiocarcinoma, and simply noted in like a sentence that it should be staged the same as hepatocellular carcinoma, which really makes no sense because these are 2 different diseases. There have been 2 Japanese groups who had proposed distinct staging systems for intrahepatic cholangiocarcinoma, but these staging systems really weren't robust, did not reach statistical significance, and never really caught on worldwide. And now, over a decade ago, working with Dr. Hari Nathan, who's now attending at University of Michigan, our group, based on some data that we published, proposed a new simplified staging system for intrahepatic cholangiocarcinoma that was based on the presence of multifocal disease and also the presence or absence of vascular invasion. And one of the things I'm probably most proud about is that our research was recognized by the AJCC UICC staging manual and was actually incorporated into the 7th edition. And now, since the 7th edition and 8th edition, there is a staging system for intrahepatic cholangiocarcinoma. And as surgeons, we need to be aware of this staging system. And here I note that the T1 classification is based on size, with T1A being less than or equal to 5 centimeters, T1B being greater than 5 centimeters, and then T2 reflecting whether there is vascular invasion or not, or whether the disease is unifocal or multifocal. And this staging system has been validated by our group as well as many other surgical groups throughout the world, and really should be the standard of care of how we pathologically stage patients following hepatic resection. One other thing that we think is interesting is that our group and others have proposing this notion of a tumor burden score, which is a single composite score that takes into account the overall number and size of the lesions in the liver to derive a single composite score with regards to the overall burden of disease in the liver. And interesting, and perhaps not surprisingly, is that the overall burden of disease is strongly associated with overall survival. And you can see here that patients who have a high tumor burden score, their 5-year survival is only 17%, and their recurrence-free survival is only 7%. So we would argue that perhaps tools like this may help us as surgeons better identify who should be treated with preoperative systemic therapy or some other modality. These patients are unlikely to benefit long-term from surgical resection. So similar to pancreatic adenocarcinoma in that paradigm, where we've moved to using preoperative therapy to better define biology, this may suggest that in this subset of patients, we should be adopting that approach. Another thing that we've done is use machine learning and artificial intelligence to try to identify different subtypes of intrahepatic cholangiocarcinoma. And using that based on size, CA19-9, and the lymphocyte to neutrophil ratio, you can see here that machine learning kind of cohorted 3 distinct subsets of patients that we've classified as clusters 1, 2, and 3, being either common, proliferative, or inflammatory intrahepatic cholangiocarcinoma. And again, you can see here that patients who have inflammatory intrahepatic cholangiocarcinoma do particularly poorly. And again, perhaps this subset of patients should be treated with preoperative chemotherapy before going to surgery. We've talked a lot about surgical margin and surgical resection of the hepatic parenchyma, but the other thing that is important is whether we should be doing a lymphadenectomy as surgeons at the time of surgery. And these data would suggest that only about half of patients undergo a lymphadenectomy. But in those patients who do undergo a lymphadenectomy, the overall incidence is about 30%. And even if we presume the best case scenario that everyone who did not undergo lymphadenectomy, NX, is N0, the incidence would still be in the range of about 20%. So we know that the underlying incidence of lymph node disease is 20 to 30%. We also know that our group and others have tried to identify using machine learning, radiomics, and other means, can we identify which patients are most likely to have lymph nodes at the time of surgery so we can selectively use lymphadenectomy? And to date, the answer is no. These predictive tools are relatively poor, and we know that even patients with T1A disease, the incidence of lymph node metastasis is still in the range of about 10 to 15%. And therefore, we would advocate for routine lymphadenectomy at the time of surgery. Why? Because we do lymphadenectomy for every other gastrointestinal cancer, colon cancer, rectal cancer, pancreatic cancer, gallbladder cancer, because we know lymph node status is extremely prognostically important, as can be seen here. And we would argue that if you do not gather the information on lymph node status, you might as well not stage the patient at all. Because once patients have N1 disease, what's driving their prognosis is not the T category factors like vascular invasion or single or multifocal disease. It's really the fact that they have metastatic disease in their nodal basin. So as surgeons, it's important to do a lymphadenectomy, and it's also important to know which lymph node stations need to be dissected at the time of surgery. And these, again, are some data from the Liver Cancer Study Group of Japan showing that there is some laterality to the drainage of the liver. So when a tumor is located in the right hemiliver, groups 1 and 2 should be dissected and evaluated. So not only station 12, which is the hepatoduodenal ligament, but also 7, 8, 9, and 13. But when the tumor is located in the left hemiliver, the surgeon should also evaluate lymph node stations 1 and 3 around the celiac artery and the periesophageal area, as this is another common location of lymphatic drainage for tumors in the left hemiliver. And it's important to dissect these various nodal basins because, as this paper that we published in Annals of Surgery showed, that in patients who have nodal metastases beyond lymph node 12, that their prognosis is significantly worse, and metastasis in nodal stations beyond 12 likely represent second echelon disease with the worst prognosis. Ideally, we would like to harvest 6 lymph nodes at the time of surgery, as this is the recommendation in the AJCC UICC manual. However, unfortunately, if you look at population data, you will note that only about 50% of patients even have 1 lymph node evaluated, and only about 15% of patients reach the recommended threshold of 6 lymph nodes. And despite these large liver operations and these clearance of the nodal basins, the outcomes following resection remain poor. And in this paper that we published in Cancer, the overall probability of a true cure at 10 years remains very low at only about 10%. And the reason for this is that patients recur. And if I look at this survival curve, it reminds me a little bit of the survival curve after a Whipple for pancreatic adenocarcinoma. And we know that similar to pancreatic cancer, patients with intrahepatic cholangiocarcinoma recur often and they recur early. If you look at these data, 55% of patients experience a recurrence less than 2 years following surgical resection. And the other thing that's interesting to note, that about 50% of patients had an extrahepatic site of recurrence as a component of their failure. And in this paper that we just published in JAMA Surgery a couple of years ago, we noted that actually 1 in 5 patients will actually recur within 6 months following surgery, which I think is very sobering. Do a large operation on a patient, take out half their liver, 3/4 of their liver, and then 1 in 5 are recurring after that type of operation. So we have made available an online calculator that can help estimate the risk of very early recurrence. And we believe tools like this will help inform us about which patients are going to be at prohibitively high risk of recurrence, specifically those patients with multiple lesions, those patients with preoperative lymph node metastases. And then we can better integrate not only adjuvant therapy, but more effective systemic and targeted therapy in the preoperative setting, which we're going to hear about from Dr. Aurora Chowdhury after the break. So I want to conclude. Hopefully I've highlighted that intrahepatic cholangiocarcinoma is a serious disease with a high case fatality. As surgeons, we should strive for a margin negative resection. I firmly believe that routine lymphadenectomy should be performed in all patients, and that as surgeons, we need to be a little bit more selective, perhaps, in who we're taking to the operating room right away, as perhaps certain subgroups of patients, in particular those with a high tumor burden score or inflammatory proliferase subtypes, may benefit from preoperative therapy to sort out their biology before taking them for operative resection. And therefore, we really need to adopt a multimodality approach if we hope to increase and improve the overall survival and outcomes of these patients. So